I'm Anne Butts. I'm a registered nurse, have been for 40 years, doing all sorts of roles, including facilitating these monthly forums for Devon Care Homes Collaborative and with Indigo Development. Sarah will be presenting for us today on the importance of documentation in social care. So a lot of you probably already know Sarah. She's an extremely experienced nurse. Again, she's not very near. I shouldn't be giving away your age, Sarah, but similar amount of time as a registered nurse as myself. And Sarah's worked in the acute, in a lot of time in social care, in 111. She's a recognised authoress, all sorts of things that Sarah's done, but she's got really great experience around documentation and the importance of that. And so really grateful to Sarah presenting today. Thank you, Sarah. What we will do, thank you, we will ask if you've got questions you think of as Sarah's going through her presentation, please put them in the chat bar. Then at the end of Sarah's presentation, we'll have a question and answer session. So please use your little hand at the top, to identify I'd like to ask a question. And we'll also come back to any questions or suggestions that are in the chat bar. What's really lovely with these forums is when we get real sharing. So different people coming up with different ideas. We had a lot of that at last month's forum around tissue viability and wound care. People talking about problems they had and other people making suggestions of things that they've said worked, or things to try. And that's the value. It's all about us sharing our learning best practice, which is really helpful for everybody. I will also post a link for the feedback. It literally, you can do it in 2 minutes. You honestly can. But we need to have those feedbacks to evidence if there's a desire for the forum to continue, and also suggestions that people put in there for further forums we can then look at asking somebody to present for. So without further ado, I will say, when it comes to the questions and answers session, please do put your cameras on if you can. It's really quite disconcerting as a presenter when you just see a blank screen. So don't worry too much during Sarah's presentation, because we'll all be looking at the presentation, but afterwards, please do put your cameras on. Please use the chat facility, and please put your name, your role, where you work, and your email address in the chat. So Sarah, if you're happy, I'll hand straight over to you.
That's lovely. Thank you, Anne.
Thank you.
So welcome, everyone. As Anne said, those of you that have met me on the forum before, and for those that don't, I've been a registered nurse for 40 years, worked in many sectors, but a large amount of time in social care. And I now support in a learning and development role around the importance of documentation in social care. So I'm looking to share some knowledge, share some experience, but obviously we all come from different backgrounds. So the question and answer at the end and any reflection is always individual, and we can apply anything we learn in our own individual ways. So we've probably all heard the phrase, if it isn't documented, it hasn't been done. This, or a version of this phrase, I've heard throughout the whole of my career, and more so increasingly of late, as more credence is applied to providing evidence to not only the care we provide, but the way that we conduct assessments and risk assessments to make sure that we have the most appropriate care plans in place to reduce the risk of harm. So what we're going to look at for learning outcomes today is to understand the role that documentation plays in the safe and accountable delivery of care. We're going to look to be able to recognise what the impact is of poor documentation in practice and on outcomes. And we're going to look at a person-centred approach to creating effective care plans. So what we do know about documentation, and specifically in social care, that it lays the foundation for our staff teams to be able to provide safe and effective care. If they don't have this guidance, it's very difficult not only for them to provide the care, but for us as nurses and leaders in social care to be able to monitor whether or not the actions or risks are appropriate and whether we've put appropriate plans in place. So the why is around the structure that it enables us to give. It helps us to meet our professional and legal requirements. It serves to protect the people that we care for. Maybe you may call the residents, service users, clients, whatever. It protects our staff, our team members, relatives, and it protects service providers, organisations as a whole. Effective documentation supports continuity of care and being able to evidence that. And it also provides the basis for us to evidence the clinical decision making that backs up any risks or actions that we put into care plans. And for those of you on the call that are nurses, obviously we have also our accountability under the NMC code, which we will talk about aligning to in a little bit. So the requirements around documentation, some of it is legal, some of it is regulatory, and some of it is best practice. And often it will be a combination of these. So effective documentation supports legal requirements such as the Health and Social Care Act 2008. Depending on where you are in the country, it supports maintaining our regulatory compliance with either the CQC or CIW if you are in Wales. It supports with legislation around data protection, safeguarding, and as I mentioned previously, the NMC duty of candour. And the best practice that we align with this helps to evidence and maintain safe governance for the people we care for and the team members that help us to provide the care. It supports inspection readiness. So when you have an unannounced or an announced inspection from your regulator, having good documentation in place helps you to be best prepared for that. And it also provides legal protection to the service provider, to you as nurses or members of a team within social care. So we mentioned the NMC. So documentation is an area that is referred to in many parts of the code. The code is quite an extensive document for those of you that are nurses, but it focuses on 4 key areas that we evidence that we prioritize people, we evidence that we practice effectively, we preserve safety, and we promote professionalism and trust. And particularly with documentation, the last one there, promoting professionalism and trust. As a nurse, when you give clinical oversight or you make a clinical rationale for a decision, for a risk or an action that you put in a care plan, it's really important that you align that with your personal professional knowledge, any trusted providers that you've gathered information from or that you collaborate with to make these decisions. Okay, because we very rarely make 100% solo decisions. Often we may collaborate with fellow nurses on our teams. It may be a clinical governance oversight that you have in your organisation, or it could be with external healthcare professionals. So the way that we document and evidence that is crucial. So to give it some context, we'll just briefly look at the legal impact that poor documentation practice can have. So what this does is highlight the significant risks around poor record keeping. Now, there is a report that's called The Prevention of Future Deaths, and you can find this online. And it reports on well, specifically in relation to social care homes, and it looks into incidences where it can be found that care homes have failed to maintain adequate records to ensure that they can safeguard their residents against harm. Okay, now I took a snapshot of 16 reports that were based in the care home setting, and all 16 had contributing factors relating back to documentation in social care, okay, that led to an increased risk of harm to the residents. Two of the reports found serious failures in documentation around unwitnessed falls that actually led to resident deaths. And in these cases, it either focused on that the incidents were not recorded or they were poorly recorded, which didn't give a clear line of being able to identify risks, lack of investigation and clinical oversight, and that care plans were not updated. And a big thing in the background of many of these reports is that the daily notes failed to accurately reflect the resident's condition. And as we all know, our team members, our staff are the eyes and ears. They feed us with information as registered nurses to be able to assess risk and plan care. And if we don't get that information, either verbally or in our notes, we can't be 100% sure that we are assessing accurately or that we are making the correct clinical decisions. But if it isn't written down, as far as the law goes, it didn't happen. Okay, so in summary, from looking at these, we can see the trends are around poor record keeping, the lack of incident reporting, the failure to review the care that contributed to missed opportunities to prevent harm, and significant concerns were raised around safety, accountability, and the quality of care. We all hope that every day everybody comes to work to do their best. Nobody comes to do a bad job. But if we can't prove that intent within our documentation, if something happens, this will be where this gets picked apart in the legal arena. So how do we make sure that we use the most appropriate tools to make sure our documentation is underpinned? So we use what different organizations might have different terms, and depending where you are, you might have different terms, but what we like to call clinically enabling tools. So clinical information that's gathered that helps to support your decision making. So this might include the care plans that you form for each individual resident, the risk assessments that you use in the background to be able to formulate the care and actions that are needed. So that could be around mobility and falls, it could be nutrition, it could be pressure area care, skin integrity. So all of the areas that we assess. The use of body maps. So when we have got skin integrity issues, that we've got clinical photography, that we've got measurements, all the clinical data that we would need to assess and implement care. The use of fluid balance charts, behavior charts, the use of SBARD as a communication tool if we are escalating for advice or support from other healthcare professionals, and the use of the News 2 Restore 2 charts. So these are not specialist tools. These are tools which are in our everyday use within the social care setting. And we use these tools to be able to support the early recognition of deterioration. We would use Restore 2, News 2, SBARD to guide consistent interventions. So advice that you got through collating assessments of risks and collaborating with other healthcare professionals or your team to make a clinical decision, and to promote the safe escalation. So again, we would use all of these tools to do that. Now, those of you that joined the forum in the early part of last year when we started might remember the ADPI session that we did. And the use of ADPI closely aligns, even if you don't do it in a formal basis, adopting the principles of it helps you to ensure that you consider everything when you are trying to make sure that you've got all the information you need for a clinical decision making. So we start with the assessment, the diagnosis, any planning that we find we need to do, put in place following those assessments and keeping the diagnosis in mind, the implementation of the plan that we've made, and then evaluating the efficacy of that plan feeds back into assessment again. So it is a loop. It's never just one job that's done and then that's left in place. We will change the frequency of the assessments that we do based on the evaluation that we get on the implemented plans. So it's a constant work in progress. And whether you record this formally or informally, whether you use the acronym or you don't, if you can evidence these steps, then it is a good underpinning for the clinically enabling tool use in social care. So I've mentioned risks a couple of times there, and obviously, we're probably all familiar with, risk assessments. So just want to be clear what we might think of as the risks associated to poor documentation. So poor documentation or incomplete, so this can be incomplete care notes, it can be incomplete or lack of detailed care plans, can lead to unsafe or inconsistent care. Care plans are there to guide your teams and to give them knowledge that they can provide the most appropriate, safe care for your residents. Medication errors are a risk when there is poor documentation. So inaccurately transcribed medications onto a MAR chart, for example. Missed signs of deterioration. So not using Restore 2 effectively. Incomplete News 2 scores, which become useless to professionals when they're trying to support you if you haven't got an accurate score. Safeguarding failures, either that they are not escalated to safeguarding or that they are not accurately and detailed submissions to the safeguarding team so that they can support and advise accordingly. Poor documentation can be raised during regulatory inspections and can result in enforcement actions from your regulator. They can also lead to legal claims against individuals or the service user / organisation. And for nurses, it can lead to NMC, fitness to practice concerns. So everything that we do as a nurse, is done under that umbrella of the code, and we are responsible for that at all times. So a phrase that is very common within social care is around person-centered care plans. And I just want to have a brief look about why they are so important. Not because I'm trying to teach you to suck eggs or anything, but if you keep in mind, we're talking about the importance of documentation. So the person that we're caring for is at the center of everything that we do, every decision that we make, every risk that we identify and assess, and every plan of care that we put in place, and also every evaluation of that care plan that takes place. So care plans need to provide us with a translation of risk. So we assess a risk and we complete an assessment, and that has to be translated into an action that goes into a care plan. Otherwise, there is no point in doing the risk assessment. It also gives you the tool to provide clear, accurate guidance to your staff teams so that they know what to do. And then if they don't do those things, you can use that as a learning and development tool for their onward education and improvement of standards within your social care setting. It also helps to ensure continuity, between day teams, night teams, team members or staff that work part-time and full-time. Communication can be a real challenge in social care with either 12-hour shifts or people that only work weekends. So clear and accurate documentation around care plans is key. We want to reduce the variation in the care delivery. So we want to maintain that consistency. So everybody who is delivering care needs to have access to the care plans and the actions that you've put in place. And all of that helps to support the safe delegation of duties. You know the skill set of your teams better than anybody else. And you know who is safe to delegate to based on that. How would someone unfamiliar with your residents or the people you serve, how would they know how to safely delegate if they don't have a person-centered care plan to refer to? So the signs of an effective care plan, that they have the individual at the center of everything and they reflect their preferences and wishes, that they have a capture of their life history and routines that are meaningful to them. And this is important in social care and particularly important in people who are on a cognitive journey, for example, dementia, complex care. It gives you the tool to be able to balance risk, actions for risk, and the rights of your resident, which have to be at the centre of everything that we do to ensure that we continue and strive to empower them in this process. We obviously are always aiming to promote independence and dignity in everything that we do, every single minute of every single day, and that we consider capacity considerations when we are looking to evidence consent for either the care plan formulation, the content of the care plan, or the way that we believe as clinicians that we would want to implement it. So if we keep that in mind, we, as a short sort of overview, we want to reflect what we currently see. So a snapshot of what's happening right now, set the timeframes for them to be reviewed, which will vary with every individual based on the risks that you've assessed, identified and planned for, and ensure that everything that's in these care plans is evidence-based. Okay, as nurses, we evidence-base everything we do, but sometimes the evidence isn't recorded in the care plans. So what does best practice around documentation look like? So there's nothing new that probably none of you have, you've all heard of these things before, and the things that we all know are best practice, not only in documentation, but in communication and care delivery. So timely recording of notes. You do not need to be told at 7:30 in the evening that someone had a fall at 10 in the morning. You can't clinically assess the impact of that if you get that data hours later. So it's the timely recording of the care notes, incident forms, identification of a medication error, concerns raised by a relative, whatever it is, needs to be recorded as soon as possible, because we're all only human. We forget things. We're busy every single day. And if you don't record it, chances are that if you do record later, it will be a shortened version of what you actually wanted to capture. The documentation needs to be objective and it needs to be factual. A documentation entry that is based on assumptions or opinions or is observed to be judgmental is not going to carry the weight that a factual entry. A short factual entry is better than one big story that doesn't actually hold context to what has been observed. As we mentioned previously, the documentation needs to be person-centered. It's purely about that person, their needs, their choices, their preferences, and how we've kept them at the center of what we're recording. Their feelings, their expressions. If they've said a phrase, capture the phrase, because you never know when that's going to be needed. Notes need to be clear and concise. We don't need to use jargon. I worked in lots of different places, and acronyms are all over the place. Whether you work in a hospital or you work in a care home, acronyms are there every single day, but not everybody knows what they stand for. So, we as clinicians, we need to try and be really mindful that when we are documenting, would someone else understand what I've written? And would they be able to learn from that what I captured? And if the answer is no, you need to reframe it. And it needs to be accurate. So we all make spelling mistakes, and depending on whether you're still on paper system or whether you're on digital, some forms have, a spell check facility in the background. But if it is a paper system, It can't have correction fluid on it because these are legal documents, just as your digital records are. And crossing out should be a single line and not a big scribble across the page. Same with paper MAR charts. These are legal documents that evidence the clinical actions that you have advised, made, or implemented. And if they were used in a coroner's court in that condition, it would be the individual that has written them that would be held accountable for that. So on our whistle-stop tour through documentation, we've looked at the role of the documentation and the delivery of safe and accountable care. We've recognised what the impact is of the poor documentation by looking at those legal cases, and we've examined the importance of the person-centred approach. Now, I really appreciate everybody that's joined today.